Hello, everyone. Welcome to the Essential Substance Abuse Skills webinar series. I am Natasha Peterson, and today Steve Steiny will be presenting basic counseling skills. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC Network, which also includes 10 regional centers, 5 international centers, a network coordinating office, and the National Hispanic and Latino ATTC. We are located at the University of Iowa. In the next couple of days, we will send out a follow-up email to everyone who attended, which includes a link to the recording, the handouts of the slides, and a CEU request form. Our center is a NAA DAC NADAC certified educational provider, and we'd be happy to provide you with CEUs for a $15 fee. Immediately following today's webinar, you will be redirected to our Get Right evaluation. This survey takes just a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion and would greatly appreciate your time and sharing your thoughts with us. You will be muted for the duration of this webinar. Please use the chat pod to share your questions and comments, and we will address questions at appropriate times during the presentation. It looks like we might be having some problems with our audio. If you can hear me, would you type into the chat box? Thanks so much. Okay, so it looks like we have some people that can hear us and some that cannot. If you are having problems with your audio, if you can look at your bottom left-hand corner of your screen and call the conference line 800-832-0736, and it's room number 4700964. Otherwise, you can try increasing the volume on your computer. And so we'll continue on. Thanks so much. So today's speaker is Steve Steiny. Steve is our program manager for the Tribal Opioid Response Project with the ATTC and has been an alcohol and drug counselor since 1997. He has worked in the behavioral health services and nonprofit sector for the past 23 years, has been in recovery for over 31 years, and has committed his life and profession to helping others in the recovery process. So thank you so much for being with us today, Steve. It looks like we still might have some problems with audio, so if you could hold on for 1 second, let's see if we can try to remedy that. Thanks so much.
That sounds great. Good morning, everyone, or afternoon, depending on what time zone you find yourself in. I'm sorry to hear some of you can't hear the broadcast today. So let's wait a couple more minutes and we'll see if we can't get everyone on. Can you all hear me okay? Fantastic. Well, again, good morning or afternoon. My name is Steve Steiny, as Natasha said. and just want to welcome you all to today's presentation. I am coming to you live from our National Addiction Technology Transfer Center here in Iowa City, Iowa. University of Iowa. We're on campus in the College of Public Health. And I'm really honored to be here today. This is my first broadcast in this format, so I'm hoping that I can relay a lot of information to you today and exchange some ideas and thoughts as we go. And hopefully we won't run out of time. And if we do, we can always correspond after today's broadcast. But I did want to, before we get started, I did want to say thank you to our program director, Anne-Helene Skinstad, and our co-director, Sean Baer, for providing me with an opportunity to talk with you all today. And I can also share with you that, again, this is my first run-through with this format and the PowerPoint today, so please be patient with me. I'm born and raised in Iowa, and I've worked in the addictions field for the last 23 years, and finally made a change here in January of this year. So I'm learning, and I am hopefully going to be able to provide some information today that will be helpful. I will also assume that many of you are preparing to enter the field, to work in the field as addiction counselors or behavioral health counselors or clinicians, and would hope that this information helps you in preparation for taking a certification exam or a licensure exam of some kind. So I think what we'll do, we have a lot of information to cover, and I'm certainly hoping that we have a chance to field some questions as we go, and again, hopefully the technical difficulties won't interfere with the process. So why don't we get started? Again, there's a lot of information to cover. I'm going through this for the first time, so please bear with me, and look forward to having a dialogue. I've done a lot of presentations in the past. It's usually with an audience. I like to be interactive with my audiences, and certainly won't have the same opportunity to do that with all of you today. But I do thank you for your time and attendance, and I really look forward to sharing some information with you. I do want to state before we get started too that the Addiction Technology Transfer Center, our mission here is to serve as subject matter experts and key authorities on resources for culturally appropriate prevention practices, addiction treatment, recovery, and mental health services. In these roles, we aspire to support behavioral health professionals working with American Indian and Alaska Native communities suffering from substance use and other behavioral health disorders, and providing technical assistance to communities in crisis due to mental health or addiction epidemic. By partnering with local American Indian and Alaska Native behavioral health workforce members, we utilize indigenous knowledge to create culturally informed experiences for providers and clients. Please take a look at our website if you have a chance, our national website, for more information. Okay, why don't we get started? Natasha, I am going to begin here, so hopefully we're okay. Let's just start off. I want to kind of take a look at our goals and objectives for today. And again, we have quite a bit of information to cover. So I'm hoping that we will be able to have a dialogue with this information as we go, and I can share with you what I know. One of the things, and let's go next slide, please. One of the things I want you to keep in mind as we're talking today, and it's really been a really integral part of my work as a clinician and a professional working in the addictions field, is this, and I hope that this would make sense to you. A person's substance use is not the problem, but rather a symptom of an underlying issue for which they have yet to find a meaningful solution. I hope that makes sense. It's really been an important part of my understanding and working with patients in the addictions population. It really tells me that a person's substance use really is not the problem, but rather an indication that they're struggling with some underlying, what we would call co-occurring or comorbid issues that they have yet to figure out a better way to work through. So keep that in mind as we go. And again, I'm hoping that we can continue to have a discussion and a dialogue as I share more information. Let's start by looking at some what I would say. It says here counselor development, but I'll use the term professional development. I'll also use some interchangeable terms today. I'll use the term clinician interchangeably with counselor, or therapist interchangeably with clinician. And I'll also use the word patient rather than client, but they are interchangeable. So whatever works for you is fine with me. But let's take a look. Let's take a look now at first and foremost. Let's go next slide, Natasha. Let's go and look at the process of thinking and reasoning. So one of the things we can look at, there's really two ways that a person may see the world and learn and understand. One of them is this global thinking, the process wherein the answer is sort of stated within the argument. It assumes that what I'm trying to prove is true, that the conclusion is a single assumption. There's a certain starting point, and the thought process tends to jump forward and from side to side through the steps of a project in order to see the big picture and to tackle those areas where they have most interest. So A is B, therefore B is A. That's one approach. Let's go next slide. The other thing that I would look at is the linear thinking process. Now for me, I relate more to the linear thinking process. It's a process of thought following known step-by-step progress wherein a response to a step must be elicited before another step is taken. It has a starting point and an end point, often utilized in problem solving. A equals B, B equals C, rather than A equals C. So a significant difference between circular and linear thinking is that global thinking is the conclusion itself is contained in a single creative assumption, whereas linear thinking, the conclusion is derived from multiple assumptions. Okay, let's go to the next slide. So everyone has sort of a different learning process, and I want to look at 3 different ways that one might learn, and I think this applies to, remember, as your development professionally, as you absorb and gather information from your supervisor and your colleagues and peers, or in your personal life as you learn something new. Everyone has a little bit different learning process, and really the way to look at this is in kind of 3 different ways. One is the visual learner, using some of the examples listed below. Another form of learning is auditory. You can see some examples listed there as well. And then kinesthetic learning, which is, again, there's some examples of ways in which someone would learn, or their learning process is more kinesthetic. So be thinking about this as we talk a little bit about ways of learning, because these can really be important for you to understand, and for those that you're working with and learning from as you process through and develop professionally. So let's go next slide. So think about how you learn or process information, global or linear thinking. How do you process information presented to you? Who in your life do you believe um, who in your life do you believe processes information on the other end of the scale from you? And how do you adjust your communication when speaking with a person who processes differently than you do? This can be a challenge sometimes, both from the learner and the educator. So, visual, auditory, or kinesthetic learning. How do you feel you learn the best? Myself, I think I am sort of a combination of visual and kinesthetic, but I can relate to all three of those categories we looked at earlier. Let's go next slide. So here's our first question. Natasha, do you want to go ahead and distribute the polling question?
Yes, if you look in the bottom right hand of your screen, there will be an opportunity for you to choose which learning process you most identify with, and you should be able to see the results there.
So we'll wait a few minutes here to get that information in, those results in. Looks like we've got a lot of visual learners on our hands. I knew there was a reason I liked you guys. Okay. Looks like we're still tabulating a few votes. Natasha, how do we know when we're done?
You can move on whenever you'd like. We can just keep going.
Oh, okay, we'll come back to the results on that. So again, that's just a brief overview of different ways people absorb and learn information. Let's go next slide. So this next slide is really it's an integrative developmental model. I want you to think of this as a kind of progressive theory of your own professional development as a clinician, either working in the field or getting ready to work in the addictions field or behavioral health field. Does that make sense to everybody? Okay, let's keep going. So the integrated developmental model of Stoltenberg, McNeil, and Delworth, developed in the late 80s, really took a look at sort of the progression that a clinician or counselor would go through as they come in and work into the field. The clinician, they say that a clinician develops in a step-by-step approach, that clinicians are seen to move through 3 levels of development in a relatively orderly fashion, relevant to what they're doing within their job as they learn. The model allows for brief regressions when clinicians or counselors are faced with new or unclear tasks. This makes sense to me. In my many years of training and assisting new clinicians entering the field, it was always very important to provide step-by-step orientation and clinical training, which would often start with understanding and building upon their concept of our assessment or evaluation process, just as an example. Because this was essential for the clinician to know and be well versed with so that they could determine what the patient's social and diagnostic histories were, and then, of course, recommendations beyond that. I think of it as building a foundation for a house, and we all know that you need to have a solid foundation if you expect the house to stand and function in the years to come. Does that make sense? Let's keep going. The integrated developmental model says that people are continuously growing, and growth is not linear but sporadic. And I like that concept. Growth can be affected by changes such as caseload, treatment setting, supervisory relationships, and the patient population being served. It makes sense to me. It really does. I hope it makes sense to all of you as you reflect on your own developmental process in the helping professions. So again, if we look at in the integrated developmental model, if we look at the levels of counselor development, beginning is really three levels: beginning, intermediate, and advanced. And then within these different levels, we have these overriding structures that include sort of in the beginning being very self-aware and aware of others. In the intermediate stages, being really motivated to try and develop your own theoretical approach and techniques and strategies. And then lastly, in the advanced stage, really reaching a point where you are functioning autonomously and being able to provide services with little to no oversight. So again, if we look at the integrated model, let's go next slide. So if we look at the integrated developmental model, you see they identify 8 growth areas: intervention, skills, competency, assessment techniques, interpersonal assessment, patient conceptualization, individual differences, theoretical orientation, treatment plans and goals, and professional ethics. Let's go next slide. So again, let's go back and understand these levels of the clinician's development. The levels of counselor or clinician development, again, beginning, level 1, intermediate, level 2, and advanced, level 3. In level 1, clinicians are full of trust and hope. They are really relying on their mentor or supervisor and colleagues to help guide them, and they are very open to assistance and help. We would often use shadowing and mentoring in my clinic to help new clinicians coming in. It was absolutely vital that they had examples and could watch new clinicians or experienced clinicians function when they were, so that they could observe and watch this happen as new clinicians. Level 2, this can involve some confusion, maybe some ambivalence. In level 2, the clinician is trying to be independent, maybe not trying to be as imitative or follow their mentor as much. They may be also struggling with letting go of some of their own attitudes or belief systems coming into their job, and trying to come to terms with those as it relates to their professional development. And then lastly, level 3 is sort of the calm after the storm. They're able to concentrate, demonstrate some level of development, and have some skill set to rely on, and also understanding that this process is an ongoing, lifelong process. Level 3 I would describe really as the beginning of a clinician's true work experience. As the clinician develops beyond this stage of growth and understanding, their work will take on more meaning, both professionally and personally and spiritually. Let's go next slide. Okay, so we're gonna keep going. We have a lot to cover, so I want to make sure that we don't slow down too much. So if I'm going too fast, I do apologize. But again, I'm learning with all of you and going through this together, so I appreciate your patience and your attention. Let's look at some micro-counseling skills. I think Dr. Alan Ivy is sort of the creator of these and the originator of these set of
Your
skills.
microphone has been turned on.
I really believe that these micro-counseling skills can be learned. And I would safely venture to say that those of you listening today are likely innately gifted with many of the skills that we'll talk about with these micro-counseling skills. I would say that because if you weren't, I don't think you would be involved in the helping professions and trying to connect with others and help them improve the quality of their lives. I can remember taking a micro-counseling skills course in graduate school from the late Dr. Dick Dustin here at the University of Iowa in the fall of 1995. It was really reassuring to me to see that many of the skills, these micro-counseling skills, came naturally to me, but I can tell you, videotaping yourself and having your peers and Dr. Dustin review and give you feedback for almost 16 weeks made me much more mindful of what I was doing and why. And it was really an important learning process for me. So I would encourage any of you, if you have a chance or an opportunity, to get feedback from your peers regarding your micro-counseling skills. It can be very enriching and help broaden your understanding. Interestingly, for me, these skills would also later play out when I would recruit and hire and interview new clinicians and staff coming into our agency. They can be used in that context as well. And I'll also add, I don't know how the audience, the listening audience feels about this, but I know that sometimes I found that my micro-counseling skills didn't work real well with my family members. They didn't want me trying any of my counseling skills on them. So I don't know if any of you can relate to that, but I experienced that periodically throughout my career. Let's go to the next slide. So yes, Alan Ivy was the originator of these micro-counseling skills approach. Next slide. He authored many books and many publications over the years. I actually own the book pictured here in the top left and utilized that in my graduate school experience. But he has a lot of information out there, many publications and books to choose from. Next slide, please. So micro-counseling is really an analysis of counseling skills that looks carefully and in great detail at the elements of that therapeutic relationship. Regardless of the aims and methods of the therapeutic relationship, understanding its micro-elements helps clinicians improve their counseling effectiveness. Next slide. So looking at a couple of different aspects of micro-counseling skills, we look at issues related to active listening. And I know that's a term that I probably assume most of you are familiar with. Really, we can look at it through attending and attending behavior. So examples of this, the counselor's interest, in attending, in the attending behavior really is interest in the patient demonstrated by eye contact, body posture, and accurate verbal following. And attending behavior can be using encouragement and active listening. And I would also say just some examples. Nonverbal would be body language, eye contact, space, touch, and time. And verbal would be encouragement, asking clarifying questions to make sure you understand, restating or paraphrasing and summarizing. Next slide. Next slide, please. Oh, there. I'm sorry. Let's go back. I missed it. Sorry, Natasha. So open and closed questions. Open and closed questions, I think, too, are a really important part that Alan Ivy recognized and included in his micro-counseling skills model. Open questions cannot be answered in a few words and offer encouragement that the patient will speak more freely. Closed questions focus on dialogue and can sometimes really cut short any progress or deeper exploration that you might have with a patient by just simply asking closed-ended questions. One of my favorite open-ended questions with patients was very simple. It was just, can you tell me more about that? And this really opened it wide open, and opened it up for the patient to share what they were comfortable with when they were ready to share. So I think open-ended questions are a wonderful strategy to elicit discussion and sharing, as I said. I think closed-ended questions have their place too. I wonder if anybody could think of an instance or a situation where a closed-ended question would be beneficial. And what I would say to that is I would often train my new staff to focus on asking closed questions during the assessment or evaluation process. Because if I ask too many open-ended questions during an evaluation, that evaluation may turn from a 1-hour service into a 3-hour service, depending on how much the patient has going on in their lives. So sometimes I think utilizing closed-ended questions can be beneficial depending on the service milieu. Okay, let's try next slide. So again, in the micro-counseling skills model, the patient observation skills, reflective listening, nonverbal behavior is 85% of communication. And then verbal behavior using specific keywords. This is important. In my own early training and development as a clinician, I often wanted to solve the problem or fix things. And really my job really is, as a clinician, is more to point out discrepancies in the patient's communication, not to try and fix or solve things. I need to understand where the patient is coming from. Be mindful of this. If I'm trying to fix and solve, I sometimes can dominate the session and not give that patient an opportunity to explore solutions themselves. So your therapeutic relation relies on understanding why your patient started using alcohol and drugs in the first place. Just as I said early on in the broadcast, their substance use is not the problem. It's causing them problems, but it really is a symptom for some other underlying issues. I really hope that makes sense to all of you listening. If I take on the role of making them quit or change because I want to feel effective, I've missed the point of me connecting and working with that patient. And I think Alan Ivy understood this as well. Let's keep going. Next slide. Encouraging, paraphrasing, and summarizing. Again, working with the patient to recognize and discourage any behaviors that are inconsistent with their progress towards their treatment goals. I have to use reflective listening to make sure that not only can I encourage and paraphrase, but to make sure that I'm hearing and understanding what they're saying. Next slide. Reflecting feelings. This can also be an advanced skill, but I think with a little practice it can be done. And Alan Ivy understood that this was a vital micro-counseling skill. The patient's feelings, either reflecting feelings are the patient's feelings, either stated or implied, as expressed by the clinician. The feelings of the patient can be nonverbal or verbal. Reflecting meaning, finding the deeply held thoughts and feelings underlying life experience. This can be done through paraphrasing and breaking down complex behaviors into parts. Paraphrasing really is simply thoughts, understanding and summarizing thoughts just as I would reflect feelings. Okay, let's go. Next slide. Empathy. So empathy is, again, I would really say from my own experience, I believe that empathy is the great bridge builder in the shared human condition. I believe that. Understanding what the patient is experiencing and putting oneself in the patient's place. Functions of empathy: builds a firmer relationship with the patient, enables counselors to better understand patients' behavior, and then one of the pitfalls really can be there can be some disconnect, or empathy can appear disingenuine if there are language or cultural differences between the patient and the clinician. And I think it's important to balance your empathy so that you don't lose sight of your role and purpose as the therapist. Okay, next slide. So here we are. We have a polling question. Which of these micro-counseling skills is most challenging for you? Attending behavior, open or closed questions, reflective listening, or empathy? Okay. Looks like there's open and closed questions seem to be the early leader here in the polling. Okay. Let's go next slide. So now we're going to shift gears here. If you need to stand up and stretch a minute, or just take a couple of deep breaths, you can do that now. I think I'll do one myself. Hope everybody's holding up, and I hope everybody can hear. If you're cut off from this, there will be a recording of this broadcast for you to listen to at a later date. I do apologize. You won't be able to hear my mistakes live. You can hear them recorded later. Okay, let's look at some counseling theories. There are quite a few, and really what I want to do is look at some of the founding fathers of a lot of the counseling perspectives and theories that we see still in practice today in one form or another. First of all, let's start off with the psychoanalytic perspective or theory. This consists largely of using methods to bring out the unconscious, working through the past, and then the transference of relationships, which really is trying to understand how past relationships are affecting your current ones. That's really what that transference of relationships means. And it focuses also on childhood experiences. And it's noted here, and I agree, training is required beyond the scope of most clinicians. An advanced degree in psychology or psychiatry may be necessary, although one of the things about theoretical approaches, I will say, is that I often encouraged clinicians that I was working with or training to think about borrowing aspects of different theoretical approaches to develop their own. And so you can still use some psychoanalytic approaches without having specific training for it. Okay, let's keep going. Next slide. Okay, so again, building on psychoanalytic perspectives, yes, there he is, Sigmund Freud. His work really consisted of identifying and recognizing the struggle between life and death, instincts, and it really focusing on that at the heart of human nature. The id and superego are constantly in conflict with each other, he thought, and the ego tries to resolve this discord. If this conflict was not resolved, he thought that we tended to use defense mechanisms to reduce our anxieties. And psychoanalysis attempts to help patients were designed to really help resolve their inner conflicts. So, we also have within the realm of psychoanalytic approaches or theories is Erik Erikson. He broadened the development of the perspective beyond early childhood. He established balance between ourselves and our social world, our biosocial approach, or using a biosocial approach. Crisis, he said, was the equivalent to a turning point. Ego developing strength and ways to deal with life tasks. And he also explored personality stages. Next slide. Next up is Carl Jung, one of my really favorite psychoanalytic theorists. Did some worked and studied him in graduate school. His approach really was using this psychological aspect of personality development during midlife, and views humans positively, focused on individuation, a very spiritual approach, and the meaning of life sort of question. Constant development, growth, and moving towards a balanced and complete level of development. Really fascinating work. Any of you out there around midlife, any of you 40 to 60-year-old folk like myself, there's a book by James Hollis called Finding Meaning in the Second Half of Life. And he references a lot of Carl Jung's work in that book. It's a short read, but it's worth it if you're looking to do a little soul searching. Finding the second meaning is finding meaning in the second half of life. Great book that references Carl Jung. Let's go next slide. So the overview is psychoanalytic perspective. Its limitations, really a lack of ego strength needed for change, biological predisposition, really placed great responsibility on parenting, and it could be cost prohibitive, long-term therapy with difficult measurements of outcome and success. Contributions, conceptual framework for looking at behavior, past experiences may pertain to current life, value and role of transference. Overuse of ego defenses can keep patients from functioning effectively. This was really made clear and brought out in this psychoanalytic approach, and the role of early childhood development as an important factor to understanding why a person is struggling. Okay. So the next perspective we'll look at is by a man named Alfred Adler. And Adlerian perspective really said that the goal to help patients was to help patients identify and change their mistaken beliefs about life, and thus participate more fully in the social world. That sounds good, doesn't it? People need to understand and confront basic mistakes. Again, I like that sounds of that. Family is an important factor, and then cooperative therapy between clinician and patient. Next slide. And I will say, his emphasis on the importance of feelings of inferiority were very, he really coined the term and identified the term inferiority complex. And it recognized as an element which plays a key role in personality development. He really was the forefather of individual psychology. And he was the first to emphasize the importance of the social element in the readjustment process of the individual. He sort of carried psychiatry into the community. Its limitations, however, it was difficult to support his work and validate his work empirically, just based on the hypothesis. Detailed exploration of early childhood, early memories, and dynamics within the family. This was often difficult to do with patients. Contributions, working out an action plan to make changes in life. People are social, goal-seeking decision makers. This was realized in this approach, subjectively understanding the unique world of the individual. And this approach was also sensitive to culture and gender, well ahead of its time. Next slide. Existential perspective. Again, I think this approach can be extremely thought-provoking and applicable to specific patients. Viktor Frankl and Rollo May, their existential therapy encourages patients to evaluate their lives, beliefs, and situation, acknowledge the limitations as well as the possibilities for their lives, find meaning and purpose in their lives, develop more effective ways of communicating. It can be a really effective approach for those who are struggling to make healthy life choices and accept the consequences of these choices. Philosophical approach that influences the counselor and patient therapeutic process. Really said that we're not victims of circumstance because to a large extent we are what we choose to be. Self-awareness became part of this therapy. A process of searching for the value and meaning in life. Individual worldview, and that people are faced with anxiety of choosing to create an identity in a world that lacks meaning. Very thought-provoking. Let's go next slide. The existential perspective, the limitations, it lacks a sort of systematic statement of the principles and practices of psychotherapy. It lacks what some would say were rigorous methods. The concepts can be abstract and difficult to understand, and highly focused on the philosophical assumption of self-determination. Contributions, the person is the central focus, so the patient is the primary focus, emphasis on the human quality of the therapeutic relationship, and individual's freedom to redesign his or her life by choosing awareness. Okay, well, let's move on now. This next approach is what's known as the person-centered perspective, or person-centered theoretical approach. Carl Rogers, this was sort of an offshoot of existentialism or existentialist approaches. Carl Rogers believed that everyone had the capacity of self-directed growth, potential for understanding self, resolving their own problems without therapist's direct intervention. Therapist's role is to be rather than to do something. And again, this can be, if we go back and think about that notion to want to fix or solve the problem for the patient, this would be incongruent with this approach. Focuses on the person. Each of us has within us, by nature, a potential that we can actualize, and through which we can find meaning. Innate striving for self-actualization. Very, very humanistic approach. Really looking at the whole person, trying to treat the whole person, or what is termed holism sometimes. Let's move through to the next slide. Person-centered perspective, limitations, we can see them listed there. Quite a few. Let's go to the next slide. This is a nice segue. I added this piece to the presentation. I don't know how many of you are familiar with motivational interviewing, but certainly this approach is widely used.
Steve, could you bring your mic a little bit
contemporarily.
closer to you, or talk a tiny bit louder? I think we have. Yeah, that would be great. Thanks so much.
I always liked the Rogerian approach. So when motivational interviewing came along, and my clinic adopted this as its primary treatment model, it seemed a natural fit for our patients and those of us working with them. MI really is an motivational interviewing is a counseling approach developed in part by clinical psychologists William R. Miller and Stephen Rollnick. It is directive, client-centered counseling style for eliciting behavior change by helping patients to explore and resolve ambivalence. Let's go next slide. Yeah, sure. You bet. Is this better? Motivational interviewing is a form of directive. Uh, is a form of directive. It's client-centered psychotherapy in which patients are encouraged to explore the discrepancies between what they hope to attain in their lives and how they currently live and behave. I used to describe it in a nutshell as using specific language and techniques to empower patients toward positive lifestyle changes. Motivational interviewing is considered an evidence-based practice for treatment of substance abuse by SAMHSA and has been extensively applied in medical care as well as mental health and substance abuse treatment. Next slide. You guys hear me better now? Is this better, Natasha? Oh, good. Thank you for letting me know. Again, motivational interviewing has some limitations, and it also has some contributions, as you can see listed here. One of the things that I think is important is in this motivational interviewing style, it really doesn't often address the urgency for change because it really is allowing the patient, you're meeting the patient where they're at, and if they're not ready to make changes, they're not asked to do so. It also can be limited by, if you have ineffective leaders or trainers, and then there's no methodology for patients who are not ready to change. And then you can see some good contributions there as well. And I would encourage you to speak with your program director about considering adopting this theoretical approach to some of your services. It allows for the clinician to avoid the role of I'm going to make you quit or I'm going to make you do something, and rather exploring the possibility of change. So if I have a patient, for example, that was drinking or using narcotics every day, and I might sit down with them and say, I see you're using alcohol daily. Tell me what you like about that. And this really is completely opposite from me confronting them about their drinking and telling them that they need to quit right away and that they're an alcoholic. I'm really asking them, tell me what you like about your drinking, in the hopes that they may be willing to share with me what it is that's underneath or driving their alcohol use. I hope that makes sense. Let's keep going. Gestalt, boy, Fritz Perls. I don't know if any of you have a chance. I did a little research on him just to refresh my memory. But one of the techniques that I always found intriguing was the empty chair. If you're interested, all you have to do is go to like YouTube and check out. Just type in Fritz Perls techniques or empty chair, and there's some really old footage from the '60s on him working with patients. Quite intriguing. If you don't mind everybody smoking cigarettes and black and white grainy film, it's pretty good. But he really said that based on he really based his approach through this existential and phenomenological approach. That's a mouthful to say. He really based this on the premise that people must find their own way in life and accept personal responsibility if they hope to achieve maturity. That's a pretty heavy statement to really take with our patients and try and work with them. But he also said that the therapists do not aim to change their patients, rather assist in experiencing all feelings, avoid interpretations, and focus on patient behavior. It's really technique based. Check out some of those YouTubes for Fritz Perls. You'll really find them quite interesting. So the Gestalt, they had a de-emphasis, the limitations, de-emphasis on cognitions, and a few other limitations, and then it really did contribute to this idea of taking action, doing some role playing, and pays attention to verbal and nonverbal cues, and really is quite compassionate in its ability to confront patients about inconsistencies or incongruencies. Really here and now too. I like the here and now idea that Fritz Perls utilized. But it's worth checking out. Let's keep going. Control reality perspective or theoretical approach. William Glasser, he really rejected the medical model. Patients live in an external and internal world. Clinicians function as a teacher or model. And this, let's go next slide. The limitations of this approach were it really de-emphasized the counseling process. It didn't take into account the unconscious, and really it was vulnerable to the counselor who assumes the role of an expert in deciding for others. It did offer some contributions, short-term focus on dealing with conscious behavior, contract approach, and psychosis can be related to unfulfilled needs. Okay?
How come you can't hear?
Everybody okay? Behavioral perspective, Arnold Lazarus, interplay between individual and environment, based on scientific method. And he really believed that therapy is a collaborative partnership and had three major areas of development. Next slide. It had limitations and contributions as well. See those listed here. Okay, let's keep going. Next slide. Albert Ellis also, this cognitive behavioral perspective, which I think we are very familiar with now more so than ever. A lot of the cognitive behavioral therapies are viewed as evidence-based practices. But Albert Ellis, Aaron Beck, and Donald Meichenbaum were really the front runners in establishing some of the cognitive behavioral approaches that we see in today's treatment models. Next slide. They of course had limitations, and they also contributed in many ways. See those listed here. Okay. Next step. There we go. And then we have family systems perspective, which again, several theorists were involved in putting together some very important family perspectives or family systems perspectives in working with not only the identified patient, but also seeing the family's role in this. A lot of information out there right now about family systems approach, and I'm sure that many of you have utilized some of these approaches as well. Just due to time constraints, I'm going to keep moving through these. There were limitations involving the family systems perspective, and I could, having worked with a lot of families in the past, I know that sometimes it can be difficult to include family members, especially if there's high levels of conflict or dysfunction. But the family is empowered in these family systems perspective as well. So very important contributions. Next slide. So the integrated perspective, creating an integrative stance is truly a challenge. It doesn't simply mean picking bits and pieces from theories in a random fragmented manner. It's important to ask which theories provide a basis for understanding the thoughts, feelings, and behaviors. This is a long-term process. So as you develop your own understanding about your counseling style and technique, I'm sure that if you haven't already, you've found yourself identifying with different approaches in the theoretical models that are out there. The bottom line is in any approach is to do no harm. We want to help and assist and guide our patients as they consider making lifestyle changes. Let's go to that polling question number 3. which of these theories are you most drawn to? I'm sorry, we had to kind of go over them quickly, but hopefully some of you have some ideas or some experiences with this. Can you guys still hear me okay? I see some of you saying you can't hear me. I'm hoping you can hear me a little bit better. Let's go to the next slide. I'm sorry, Brandy, that you guys can't hear me very well. I'll talk with our technical team about maybe getting a headset next time. Let's shift our focus now to talking about understanding a patient's readiness to change, or just in general, a person's readiness to change. Let's go next slide. So I would ask all of you, and this is something that I would often ask my clinicians or my team members or other individuals working with patients in addictions or mental health. In general, why do you think people change? And you could ask yourself why you made changes in the past, or why, in general, a person would make changes. My experience, both professionally and personally, has been that people change when they are benefiting, when what they are benefiting is outweighed by what they are losing. So the decisions they're making, the benefits they're receiving, and the actions that they are taking, benefits they receive are being outweighed by what they are losing. I hope that makes sense. In other words, I'm more ready to make changes regarding my job when the benefits and rewards are finally outnumbered by the losses and penalties, just as an example. This can be a gradual realization, an abrupt realization, or something in between. My readiness to change might be different than yours, even though our situations are very similar. Change is challenging for me personally. I try and avoid it if I can. Others thrive on it. I have a friend named Myron who says he's a change agent. He really loves change, and I just don't understand him all very well. Let's go next slide. Using the stages of change model can really be a wonderful way, and I hope some of you are familiar with the stages of change, but Prochaska and DiClemente introduced this notion of the stages of change in the 1980s in an effort to really change the process in which people were trying to quit smoking cigarettes. That's where it started, and it's been used to characterize changes in other addictive disorders, including alcohol and drug use. Next slide. So really, and again, I'll assume some of you have seen the stages of change model and how it has sort of a circular fashion to it. But really, it starts in a pre-contemplative stage of change, and this change model put forth by Prochaska and DiClemente is also known as the trans-theoretical model of change. And it really was under this notion that they found that all of us go through these 6 stages when making significant changes, or all of us go through these 6 stages when making significant changes. In the old days, they would say, so that you can see at the top of the wheel there, it's pre-contemplated. And this is probably when a person is just simply not ready to change because they don't believe there's a problem. And I think in the old days, we would call that the person is in denial. We would say, oh, that person is in denial. And now we identify this in the field as someone in a pre-contemplative stage. And then the theory says that a person goes through different levels of readiness to change, from contemplation, preparation, action, maintenance, and then perhaps a relapse and recycle regarding that issue. In the context of substance use, this model worked very well with the motivational interviewing approach. It really said, I'm going to adjust my approach. I'm going to adjust how I connect with this patient based on their level of readiness to change. I wish we had more time to talk about that, because it's a wonderful model and really allows for patients in all different levels of readiness to change to connect and to provide feedback to each other, and for the patient to decide where they are in their level of readiness to change and why. And so hopefully some of you are familiar with this. If not, do a little research and see how it might apply to your practice or your work with patients now or in the near future. Let's go next slide. I want to talk a little bit about self-disclosure and keeping boundaries, establishing boundaries, keeping boundaries. We could probably spend all afternoon talking about this very topic. It's absolutely vital, and it is tied closely with our ethical responsibilities as clinicians and providers to a oftentimes very vulnerable population. So let's go next slide. Self-disclosure and keeping clear boundaries. Self-disclosure is sharing personal information, emotional or experiential information. Self-disclosure on the part of the counselor or therapist requires careful consideration. Consider alternatives. Patient's needs always come first. I think most of you know this. I think this is a friendly reminder. Let's go next slide. Self-disclosure and keeping clear boundaries. Well, again, some information and some studies done by Wanberg and Milkman in working with patients in the criminal justice system made some conclusions. Self-disclosure barriers. Slow down or even stop the sharing process. This is when you're trying to decide whether you should share information with the patient or not. I personally came from a clinic where we were prohibited from sharing personal information with patients, recovery status, or any other personal information. So, excuse me, I know that varies from clinic to clinic, but a patient may move away from self-focus or focus at all if you're talking about yourself. So let's move to the next slide. Informal discussion. Again, this is a term that I wasn't overly familiar with, but as I read about it a little bit, it made sense. There was some research done, and they realized that informal discussions, or kind of small talk, was occurring quite often between the clinician and the patient. Let's go next slide. And I know that, let's see if I can get there. So self-disclosure guidelines, these are just some simple guidelines that you probably have already seen something similar to this, but I would say that these are some good guidelines to just kind of keep in mind. Wait, be brief, I statements. Go next slide. Consider your patient's values and consider the impact. I think it's okay, at least in my opinion, if I wanted to relate to a patient on feeling anger, I could say I understand what it feels like to be angry. I felt that emotion before. But telling them that specifically why you're angry takes the focus off of them and may be extremely inappropriate for you to share something that you're currently dealing with. Hope that makes sense to everybody. Let's go next slide. There are pros and cons to self-disclosure. It can be a quick, fast track to building rapport and trust. It can provide validation. It can help the patient feel normal. It can reduce the power differential. It can help the patient feel as though they're not alone and provide a role model for appropriate social interactions.
Just 1 second.
And some of the drawbacks, next slide. Some of the drawbacks can be, let's see, maybe I'll just move to that next slide myself. Some of the drawbacks can compromise the professional relationship, move the focus away from the patient. It can create role confusion, and the patient may hold back or not want to share. And they can also feel pressure that the patient is into disclosing when they're not ready. Let's see if I can, there we go. So let's try that poll question number 4. Natasha, you still with me? How helpful do you think informal conversations are in therapeutic sessions? You may want to check too with your agency's policies, as this may act as an additional guideline regarding what you can and cannot self-disclose. Current research and my own clinical experience suggests that it can be slightly helpful to have some small talk before or during a session, but oftentimes it may not be necessary in a therapeutic relationship. Okay, let's keep going. Okay, we're getting closer to wrapping things up. We've got about 20 minutes. I want to make sure we stay on track. Again, I certainly appreciate everybody's time and attention, and I hope that everyone is able to hear and follow along. And we will make this broadcast available, recorded information available, so you can listen again at a later time. Is everybody hearing me okay still out there? So let's look at some cultural and ethnic issues. Now, I'm going to say, folks, I'm not native. I am, my ancestry is Northern European. I'm Norwegian and German and Scottish and some other European backgrounds. So I'm not native. So as we go through some of these issues, I want to just say that I'm still learning. I'm still becoming culturally informed, and look forward to learning from all of you, as well as Sean Baer, our co-director, who is my cultural mentor, and is teaching me as we go. So let's go next slide. So culture, a key element which enhances opportunities for change. What is culture? Culture is everything that people have, think, and do as members of a community or society. Material objects, ideas, values. It's a template that shapes behavior and consciousness within human society. It's dynamic, it's shared, it's learned. Okay. One's own culture is shaped by history, religion, ethnicity, race, geography, group members, and those subcultures within those group memberships. Okay. The addressing model. This was new to me. I found this quite enriching and enjoyed learning about this. What does it do? It gives us a framework for understanding the effect of diverse cultural influences on therapists and patients' worldviews. Helps us recognize the areas where we identify with the dominant group versus the minority group. Become more aware of how identification with dominant group can limit knowledge and experience of groups we do not identify with. Next slide. Why is it important? that's a great question. I have been learning and understanding in the last 3 months so much about Native culture and trying to also experience that through engagement and interaction with other Native tribal and community members. Knowledge of the patient's salient identities gives us clues to how the patient sees the world, what they value, how they may behave in certain situations, and how others treat them. The more we know, the closer our hypothesis will be to the patient's realities. The greater our credibility, efficiency, and accuracy may be as clinicians. So that addressing model is, here's an acronym here, which I thought was a nice breakdown and really helping me kind of remember this, so you can kind of see how that goes and what each letter is attributed to. Okay. Privilege versus oppression. I'm just looking at some of the questions coming in. And, Iris, I agree. I think with a lot of the peer recovery coaching and some of the recovery support services that are sort of becoming popular again, I think self-disclosure has a very important part in that process. So I agree with you, my friend. I think self-disclosure in the right way and under the right circumstance can be absolutely beneficial and can really make a difference, especially working with youth and young adults that are early in the recovery process, or maybe considering what that would mean to be in recovery. So thank you for that comment. Privilege versus oppression. We all have addressing areas of privilege and oppression. We tend to be more aware of oppression. Privileged areas present a greater challenge for the therapist, which I agree. We need to consciously work to increase our awareness about areas of privilege. Next slide. Increasing our awareness. Investigate our own cultural heritage. Pay attention to the influence of privilege on our understanding of cultural issues and work with patients. Educate ourselves through diverse sources of information. Develop sustained, diverse relationships. I love this part. Learn from diverse groups, not simply learn about diverse groups. I think that is so important, and I'm taking that to heart myself as I become culturally informed and learn more about American Indian and Alaska Native cultures. Let's keep going. I want to make sure that I acknowledge, though I did not meet Mr. Mackey, he was an integral part of this center and contributed in many, many ways to what we do here today. So this certainly is in memory of him. So I wish I had a chance to meet him. Just some other information regarding Native American populations, tribes, and information around the United States. 565 federally recognized American Indian tribes and Alaska Native groups in the U.S., with more than 250 different languages, different cultures, traditions, histories, and identities. In a 2010 census, 5.2 million people identified as American Indian or Alaska Native alone, in combination with other race. I'm sure that's probably up now because it's been almost 10 years since the census, and then an estimated 2 million involved in Indian Health Service population. Let's keep going. Again, just some information about nations, tribes, and bands. There's just some examples of the bands in the Dakota, Lakota, and Nakota tribes of the Sioux Nation. They're listed there. I'm learning and continuing to be open to learning more about the native peoples of this land, First Nation. Okay. This was a compelling visual image for me. What happened with the land transfer and how this is directly tied into so much of the historical trauma that I'm learning about and trying to understand on a deeper level. Next slide. Just some things to outline about Native cultural values, harmony with the environment. Individuals are part of a larger system, respect for elders, children of the future, importance of helping others, prayer and traditions. And I, even as a white middle-aged guy of European extraction, I can still relate to many of these values and can connect with many of them. And Sean and I talk about this quite a bit. So let's go next slide. Interventions with Native Americans. Development of interventions must consider the following: specific socio-political history, the continuing transfer of unresolved trauma and grief across generations. And this historical trauma is real, and I am coming to terms with that, and I'm trying to understand this, and that it is not just across one or two generations, it goes back many. So I am learning and trying to understand this through interactions with others around the country. Also to consider socioeconomic conditions, current and past experiences of racism and oppression. Tips for the clinician. And I think this is in general, but I think it also specifically applies to working with Native populations. Be aware of the many perceiving, understanding, and approaching health and wellness. Let me reread that. Beware of the many ways of perceiving, understanding, and approaching health, wellness, and healing. And again, Sean Barrett is talking with me about many of these concepts, and I find them very interesting and meaningful. So I'm learning more about this. Be careful not to misinterpret, stereotype, or otherwise mishandle encounters. Be aware that ethnicity is used to stereotype diversity and can lead to distrust. Assess the degree of acculturation in the target group. And Sean has also talked to me about this in many ways, as far as being bicultural or assimilated or practicing the culture. Very important. Seek to become more culturally responsive. And then I really like this. Take the risk to discover your own biases and stereotypes. Very important. Just not only as a person, but as a professional. Because they can and will affect your work with your patients, whether you know it or not. Let's keep going. Some cultural considerations, tips for becoming culturally responsive. Primary source of cultural information should be your patient. Boy, that makes sense. Saying to someone, I don't understand, can you help me understand, is absolutely going to the source. Multicultural skills must be personalized. Learn from your mistakes. Learn to reframe problems. Recognize your own biases and cultural perceptions, and view psychological problems as social constructs. So in
you
summary,
could direct your questions to the chat
wish
box.
we had more time to go over, to review and go back. I did want to leave a little time for questions, and this is the summary that we've gone over today. I appreciate your patience and your understanding as I have gone through and learned
It looks like we have a question from Brandy. What is the most widely used counseling technique now? I hear a lot with motivational interviews.
Brandy, I think you're pretty accurate there. I know that you have to remember that in the field, especially in the addictions field, if you go back, 30, 40, 50 years ago, almost exclusively you had clinicians working in the field who were also in recovery. And that significantly impacted the types of techniques and approaches used. Most treatment centers came out of the Minnesota or disease model approach using 12-step or self-help approaches. The shift in evolution has moved more towards evidence-based or experience-based or promising practices, utilizing things like cognitive behavioral approaches and motivational interviewing and stages of change really are at the cutting edge now of trying to adjust not only your approach but also to meet the patient where they're at and respect that and join with them and working collaboratively with them. And many funding streams and funding sources are also requiring approaches be evidence-based if the funding stream is to remain secure. So I think you're right on. Motivational interviewing is a wonderful way to connect with patients. It takes the pressure off the clinician to make them quit or do something and really allows for the patient to be empowered and have hope to make changes that will benefit them later on. Great question.
So we have a question from Bessie. What do you think of the matrix?
I think the matrix model has, it still plays a role. It has a lot of its foundations connected to more traditional 12-step approaches, but there's a culturally adapted version of the matrix, and I know that the matrix model also is really geared towards and works well with teens and young adults, and can be really effective in addressing moderate to heavy cannabis use as well. And methamphetamine use was also originally designed to address chronic methamphetamine use. But I think the matrix model is, what I like about it is it's manualized, it's transferable, and you can really utilize it in both an outpatient or an inpatient setting. And it's, like I said, it has a culturally adapted version that Sean and I actually ordered just recently to review to see how we could use that or pass that along to other tribes or native communities that were looking to implement it. Thanks, Bessie. I'm reading too some of the comments about technical difficulties, and I just want to apologize again for those of you that weren't able to hear me properly, or someone said, I think Amy said that the presentation blacked out on her. So really sorry about that. We'll look into that on this end. Thank you all.
Thanks so much for joining us. Directly after this presentation, you should be directed to a form to fill out a GIPRA. Thank you so much.